This is a really important page in your first aid book. You have to understand the progression of a myocardial infarction with a particularly high level of awareness of the potential complications that are possible at each stage, because that's how patients die. We have to know how to prevent patient death and morbidity. We are perfectly aware that myocardial infarctions occur when there is a sudden decrease in blood flow, so severe that we quickly progress from myocyte swelling, or just a temporary low level of ATP, to necrosis. We are particularly concerned about the left anterior descending coronary artery, because it has to cover the most territory, followed by the right coronary artery. The third most common artery to be concerned about is the left circumflex. Remember, the left circumflex usually comes off the left main coronary artery with the left anterior descending. So let's whip out a quick vignette. So let's say we have a 50-year-old white male. He has hypercholesterolemia plus diabetes. He was at a Justin Bieber concert with his kids, and his daughter gets pulled on the stage to dance with Justin Bieber. He gets super concerned that she might actually like his music instead of just going through some sort of phase of Bieber fever, and the dad all of a sudden starts sweating. He gets a tingling sensation in his arm that goes up his left arm and into his jaw. He starts to feel very dizzy, nauseated, and then he falls to the ground. What happened? Well, we're talking about MIs. He suffered a myocardial infarction that caused hypoperfusion to his brain. His brain didn't like that, so it caused him to pass out. The general theme behind the evolution of an MI is that it goes from swelling, so temporary reversible injury, and then you get loss of plasma membrane integrity. This leads to the onset of coagulative necrosis. This leads to acute inflammation, which is mainly mediated by polymorphonucleosides, or neutrophils. Then you get clearance of the debris by macrophages in the later stages of the inflammatory response. And then you get fibroblast induction by the macrophages to replace the necrotic tissue that was cleared by those macrophages with scar tissue and collagen deposition. So just like if you were to injure any other type of tissue that is unable to regenerate itself, the myocardium can only repair itself with fibrosis. There is no regeneration of myocytes after infarction. To get myocyte necrosis, you need a reduction in blood flow by at least 10% below normal, or severe ischemia for 30 minutes. Now let's examine what is going on to this poor fellow. So in the first 4 hours, we do not see nothing, nada, macro or microscopic changes. So nothing under the microscope, nothing grossly at autopsy if you were to have an autopsy performed now. Hopefully not. Now why? Well, the first 0 to 4 hours are time that we need for there to be sufficient leakage of intracellular enzymes and activation of other enzymes to occur before we actually have any cellular damage. There is some small change going on due to the initial hypoxic environment. Remember, the thrombus that was formed makes a heart flip over into anaerobic metabolism, which leads to a dramatic decrease in ATP and an increase in lactic acid. The decrease in ATP decreases the ability of our sodium-potassium ATPase to work. This leads to a disruption in ion balance that can severely impair depolarization ability, while simultaneously increasing our risk for cardiogenic shock or acute heart failure, because we won't be able to contract forward if we have ion imbalances. The medical name for this is just arrhythmia. Now what happens when we deprive this pump of ATP so that it cannot work? We've discussed this, but it's important to know it, so let's talk about it. This is our myocyte. It cannot pump any sodium out. It cannot pump any potassium back in. Therefore, it swells because water follows sodium. It pulls water in, causing cellular edema, and we accumulate potassium extracellularly, which is a very high risk for fatal arrhythmia due to hyperkalemia. So, high levels of potassium on the outside, arrhythmia. High levels of sodium on the inside, cellular edema. And that is exactly what we see here in this image. So let's look at the features of an MI visible in the first 4 to 12 hours. Your step 1 exam will describe the histopathologic changes or provide you an image of the microscopy. Gross features are nowhere near as high yield, but you can easily understand them if you know what is going on at the microscopic level. So we had some cellular swelling, and now we have completely progressed to cell necrosis at 4 to 12 hours, which means that we have lost plasma membrane integrity. Now what happens when we do that? Well, lots of things inside the cell can come spilling out and into the extracellular environment. This does not happen immediately, which explains why we do not see anything in the blood for the first 0 to 4 hours. What are some things that are particularly high yield for your step 1 exam that spill out from this now very leaky and potentially dead myocyte? How about lactate dehydrogenase, creatine kinase MB, and troponins, right? These are all within myocytes. If you kill the myocyte, or if you mess up its membrane, these are going to leak out. These enzymes are cytosolic. They like to get around, right? And these markers don't just hang out in the extracellular environment around these damaged myocytes. They get whisked away, they go into the lymphatics, and then they go into the venous system. And guess who's waiting at the venous system to take a blood sample? Our very helpful, friendly nurses. That is why we draw blood looking for these markers when we're concerned about a myocardial infarction. Again, after 4 hours, your window will be blank for the first 0 to 4. Not enough cell damage has progressed. It takes time. And this is also the principle behind the tetrazolium stain. So tetrazolium chloride binds lactate dehydrogenase, right? It likes this guy. So the area that infarcted no longer has any LDH present. Those cells lost their plasma membrane integrity, or they died and leaked all of their LDH. That is why this cartoon image in your first aid book describes a pale zone when you stain with this solution. There is no LDH in the infarcted area, so there is nowhere for the stain or solution to bind. It just washes away, leaving the infarcted area stainless, while the surrounding normal myocardium is stained. Now, the edema that we see is directly related to the liberation of all the intracellular contents. There are a bunch of intracellular anions that attract water from the capillaries. This pulls in a ton of fluid that makes the fibers appear wavy. In addition to that, the inflammatory response makes endothelial cells release their tightness of their junctions, and it causes leaky capillaries. Do you see how this fluid is separating these usually very straight and tight fibers? There are gaps in between the very normally straight fibers. The complications at this point in time are still arrhythmia, acute congestive heart failure, cardiogenic shock, and sudden cardiac death. Now, what about at 12 to 24 hours? Well, when we damage those cells, those myocytes, we not only liberated the cardiac markers we looked for, but we also spilled out a bunch of DNA. So lost some plasma membrane integrity, spill out DNA that contains what? Xanthine and adenosine, right? Those are some of the components of DNA that will be broken down and then liberated. The thing is that these are potent stimulators of the immune response. In addition to that, the hypoxic environment induces the transcription of hypoxia-inducible factor. We've seen this before, right? All of these turn on a bunch of inflammatory genes, and hypoxia-inducible factor in turn also includes the production of vascular endothelial growth factor. Which cells are the first to respond to an inflammatory trigger anywhere? Polymorphonuclear leukocytes, or neutrophils. So whatever the initial onslaught is, think about neutrophils as always being the first guys there, being like, hey, what up? Be the first one here. That's my job. I'm here to take care of business. Neutrophil migration starts around 12 through 24 hours, right? Now, what about reperfusion injury? We hear this term a lot, and it's important to know what it actually means, because when you take someone to the cath lab and you reperfuse them, this is a risk. So let's say we do get our patient to the catheterization lab. We either retrieve or liberate the obstruction in order to return blood flow to the myocardium. So we go in there and break up that clot or take it out of the coronary artery. And now there's a bunch of blood flow and oxygen being reintroduced into that previously ischemic area. The problem is that we have neutrophils all in the heart muscle as well, because they're trying to respond to help break down some of the necrotic myocytes. Now, what are those neutrophils going to do with the newly delivered oxygen? They're going to take it and make reactive oxygen species, because that's what they do. They take oxygen and make reactive oxygen species to destroy bacteria or whatever the immune system is telling them to attack and clear. Now, what else is being delivered in that blood that is newly reperfusing that previously infarcted myocardium? Calcium. Calcium comes with oxygen. So we introduce a bunch of calcium to these damaged sarcomeres. It doesn't matter. Those sarcomeres see calcium and they're like, oh boy, whenever we see calcium, we usually contract, right? Because they don't need any more ATP just to release and contract. They need ATP to restore the coct formation. But to actually contract, all you need is calcium. The ATP has already been used to load the myosin head in the coct conformation. So when you expose them to calcium, you can get contraction bands, which is due to the sarcomeres clamping down, and then there's no ATP for the myosin head to release and return to its original conformation. So you can get contraction band formation. So for the first 24 hours, your potential complications will always be arrhythmia, acute heart failure, cardiogenic shock, and sudden cardiac death due to the risk of ion abnormalities and infarction of the specialized conduction system that set the depolarization rate. Now, what about 24 hours to 3 days, or 72 hours? At this point, we really start to see extensive neutrophil migration and necrosis. So here we have an image. It's a high power field image of an infarction showing neutrophils and lots of nuclear debris. It is the phase of acute inflammation due to the neutrophil involvement. The nuclear debris is from dead myocytes and dead neutrophils. At this phase, we also begin to appreciate some coagulation necrosis. Remember, coagulation necrosis is due to a large influx of calcium into the cell in addition to liberation of the calcium from the sarcoplasmic reticulum. Now, what does increased intracellular calcium concentration do? It activates phospholipases, proteases, and caspases, all within the cell membrane. These enzymes denature protein from within inside of the cell. The cytoplasm and nucleus blur together, but you can still have some membrane integrity. It's still semi-intact, which means that it looks like everything just got coagulated, like you put peanut butter in the microwave at high blast. It's just now contained within that peanut butter jar, and it's just goop coagulative nonsense, right? And this is the description of coagulation necrosis. Remember, coagulation necrosis is an inflammatory stimulus because it's not regulated at apoptosis. The neutrophils are always the first guys on the scene, and they call for backup. Now we have a new potential complication of fibrinous pericarditis. Why? The inflammation is occurring in the subendocardium. So again, here's our endocardium, our myocardium, and epicardium. The risk for fibrinous pericarditis comes from the fact that if you have inflammation directly next to the pericardium, which is the epicardium, so here's our pericardium here, you can have extension of this inflammatory response into the pericardial sac. Now, what would we expect to happen from here? Well, extension of the inflammation into the pericardium. So, what do we expect the next step to be? Well, in any situation of inflammation, after neutrophils are done, you expect them to have called in the hard, dirty work of the macrophages. This is the symbol that I use to abbreviate macrophage. So after neutrophils are done, they're like, man, I'm burned out. Those first 12 to 24 hours and 24 to 72 hours, I did all the work I had to. Now macrophages are going to come in as monocytes. Remember, they change from monocytes into macrophages when they are exposed to extracellular matrix in the interstitium.